And there are sometimes it will give you a drug or a little pearl of something that is not in your notes. It's not on the slides. And if you weren't here and you weren't paying attention, you'll get that question wrong on the exam.
Like verbatim from what he
It'll
said.
be right out of his mouth. And
So,
you have to pay attention. It's super important in this class.
It's not that hard of a course. It's like, just don't be overwhelmed. Just don't get nervous. Like, if you do it just like piece by piece every single day, it's not that difficult.
Try to get this block down pat because it keeps coming back every time. Like alpha, beta keeps coming back every block here on out. So try to get this one down pat, like really, really well. Put in all your effort, you know, once you can this block.
Especially because path is generally, this is a pretty easy path block. So I would really, I agree. I would go hard on the ANS stuff because it comes back every single block.
This would be the hardest farm block?
Yeah, I think so.
Hardest farm block, but easiest path. Easiest path block.
Yeah, path keeps getting harder. Farm kind of, well.
It doesn't get harder, but you get used to it. This is the basics, right?
Yeah.
So, yeah.
And if anything's hard, definitely come to his review session for this first block.
Even if it's on a Saturday.
Yep.
It's worth it.
It's worth it. But yeah, don't get overwhelmed. It's a lot of information, but yeah, just use your time wisely. Like, you have that like 11 o'clock. It's just like, just get ready. Like, if you're gonna stay up late, make sure like you're actually doing work. If you're waking up early, make sure you do work. Because like that 4-hour gap is kind of key. Like, you don't really get that in the semester, so use that time wisely, the extra time you have.
And also have fun with it. Like, this is your clinical semester. You know, you start PD, you start pads, you start farm. Like, you actually get to like learn about how you treat things and what you treat them with. And it should be interesting for you. You should want to learn. You know what I mean? Even though it's a lot of information, you should just love learning it anyway. Because I mean, this is basically where you start, putting it all together. So.
Well, if you guys have any questions, I think we're gonna do our sessions on Thursdays. We're gonna do our sessions on Thursdays.
We'll see. I don't know.
In the freestanding.
What do you want to do?
Yeah, let's do Thursdays.
All right.
At 5.
It's not happening yet.
Andy's gonna kill us.
No, Thursday.
Thursdays. Yeah, we're gonna do Thursdays. Probably our class is in at 5, so like 5:15ish. Hopefully we can do it like most succinct we can be. So depending on things, come out and we'll just
make sure you have questions. Bring your questions. We're not going to reteach the lectures. You have to bring your questions and your concepts that you have problems with.
Just listen in class and don't be overwhelmed. I think that's the biggest thing. I think people got nervous at the beginning, like, it's not difficult. It's just like.
I mean, they're going to throw drugs at you. Just,
pay
attention. You'll be fine. It's not that bad.
All right.
And enjoy your time with Dr. Kanker.
Good luck.
See you guys.
Thank you.
Thank God.
Thank God.
Hey, I knew. Man, you can fight it out. Come in. Let's see who's the man. Here, man. He'll reclaim it.
I give him 3.
So, we'll continue from where we left yesterday. Basically, we just talked about a few things. And the most important thing we talked about yesterday was that for a drug to get absorbed, we have to remember the lipid solubility part, the water solubility part. It has not to be completely restricted to lipid soluble drugs. There has to be water solubility also, because once the drug gets absorbed through the lipid membranes, it's all water that we are looking at. So both, it has to be an equal balance of those lipid solubilities and water solubilities. Now, in addition to that, we talked about a little bit that how pH brings about a change in the properties of those drugs. Always remember, if there is no confrontation between the property of the drug and the media in which you are putting it in. That is, an acidic drug in an acidic media, it will be lipid soluble. A basic drug in a basic media will be lipid soluble. Now, important part over there was when a drug is lipid soluble, it gets absorbed. And when it is water soluble, it is easily excreted from the body. So if a person is suffering from toxicity with an acidic drug, try to make the urine basic. Because an acidic drug in a basic media will become water soluble and will be easily excreted out. So those were a few basic concepts that we talked about yesterday. Now, what are the clinical benefits? We talked about those also yesterday, that same thing, poisoning thing also. Plus even normally also if a patient is suffering from some diseases like gout. Gout is a problem with uric acid. It's an acidic drug, acidic thing that we talk about. So if you make the urine alkaline, there will be easy excretion of uric acid from the body. But if you make it acidic, there will be even more absorption and that can create a problem for these patients. Now, why remembering this was important? Because there can be clinical veneers from pathology that might be incorporated in pharmacology. We talked about like hepatic cirrhosis, that ammonia coming into the urine. Do not ever think about making the urine alkaline in those patients. Because ammonia in the alkaline urine will become more lipid soluble and will be reabsorbed back. And that can be a major problem for these patients. So there were a few clinical veneers that we talked about yesterday. Now, moving ahead. we talked about that the drug has to be absorbed, but there has to be various processes involved in that absorption. Majority of the time, when it comes to absorption, it is passive. And always remember, when it comes to passive absorption, it is down the concentration gradient. That is the most important thing. Since you are not utilizing energy, you have to go down a concentration gradient. Now, when it comes to things being absorbed down a concentration gradient, one is passive that we'll talk about. The other one is also there, which is called as facilitated diffusion. Now, when it comes to facilitated diffusion, it is down a concentration gradient, does not require energy, but it utilizes a carrier. There is a carrier protein which is taking the drug molecule inside, but does not require an energy. That's why it will be down a concentration gradient only. Then comes the third thing, which is called as active transport. Now, when it comes to active transport, this is the one which utilizes energy, and this is the one which can take the drug molecule against the concentration gradient, like from a low zone to a higher concentration zone also. So, active transport is the only one which is utilizing energy, utilizes a carrier also, a transporter also. Facilitated utilizes a carrier or a transporter, but it is down the concentration gradient. Now, one important issue here, wherever you are utilizing a carrier, what is the issue? The issue is, number one, carrier can be saturated. If you give too much of drug, my carriers can get saturated. And once the carrier gets saturated, what that will lead to? The drug will not be absorbed. Can you think of a very common example in some pathological condition? Diabetes. That's the best example. Why you get sugar in your urine? That's the reason. Those glucose transporters, they get saturated, and then that glucose starts appearing up in the urine. So, facilitated diffusion, active transport, then utilizing a carrier which can get saturated. Now, that was one issue. There is another issue also. If you are using two drugs, this is bad. When you are using two drugs which compete for the same transporter proteins, what that will lead to? That is, now you have two drugs competing for the same transporters, and you might decrease the absorption of one at the expense of the others. Now, this can be used pharmacologically for our benefits. Now, once again, we'll go back to that same disease, uric acid gout. You might be knowing that uric acid gets reabsorbed back through the tubular reabsorptive pathways. Remember those? Segment 1, segment 2, S1s and S2s? It gets reabsorbed back through those reabsorptive pathways utilizing a carrier. Now, I know that uric acid is getting reabsorbed back via carrier. I can give a drug that competes with uric acid for those carriers. And the drug name is probenecid. There's other drugs also, sulfentrazone, but remember one right now. It's supposed to be new. Hope this works. Great. These all are new ones. Probenecid. Now, this particular drug competes with uric acid. Now, when you compete with uric acid will not be reabsorbed back, and that's what you want in a patient of gout. You lose it through the urine. Now, we can utilize this for other benefits also. Must be knowing of a drug by the name of penicillins. Must be knowing those. Microbiology, beta-lactams, cell wall synthesis inhibitors, very important drugs. We have cephalosporins, we have penicillins. Now, problem with penicillin is it has got a very short half-life, only about 2 to 3 hours. You cannot use a drug that has a short half-life to that extent. The reason being is you will have to re-administer it again and again to a patient, and that decreases the compliance. You cannot ask a patient any injectable preparation or even an oral preparation to be repeated every 2 hours or 3 hours, 10, 12 times a day. That is basically not possible at all. People will not have a good compliance for that particular drug. So what we do? We know that penicillin gets excreted through the urine utilizing those tubular secretory sites. Now remember, in the glomerulus, when you go to the lumen, in the proximal tubules, you have those secretory sites as well as reabsorptive sites. The reabsorptive site we already have talked about uric acid, that it gets reabsorbed through these transporters. Penicillin comes into the urine and gets excreted by utilizing these secretory sites. Same thing. Give penicillin with probenecid. Probenecid will utilize these carriers. Penicillin will not be able to come in the urine and will stay longer inside your body. That's what we normally do. So that is another thing that can be done with these drugs. Those are a few examples that can be used for our benefit pharmacologically. Now, moving ahead, we just talked about those passive diffusion a little bit more. When it comes to passive diffusion, we already have talked about that it is down a concentration gradient. Number one, you are not utilizing any transporters, you are not utilizing any energies. It is non-saturated, it will never saturate till the concentration is there. It can be of two types, aqueous diffusion and lipid diffusion. Lipid soluble drugs through the lipid membranes, aqueous diffusion through those aqueous pores which are present in the capillaries, those will come in. So that is basically a little bit about those. Now when it comes to this passive diffusion, which is aqueous or as well as lipid, it is governed by a principle that is called as Fick's principle. Remember yesterday we talked about that when it comes to absorption, we were depending on certain things. Which were those? One was
surface area.
Surface area was one, then we have the concentration gradients, those solubilities and all those things we have already talked about. Thickness was the one thing that was we were inversely proportional to it. So basically Fick's principle comes out of that only. There is nothing new over there with Fick's principle. This is what it is. That the rate at which the drug will moving through the membranes or will be absorbed is equal to C1 minus C2, which is your concentration gradient times the permeability coefficient. Every membrane has a permeability coefficient. We know that. Times the area divided by the thickness. We are not putting that molecular weight thing over here. That was just to tell you that molecular weight do play a part. And when a drug which is highly plasma protein bound, it gets stuck to that particular area, does not move around much. So always remember, larger size drugs are difficult to move around. So this was our Fick's principle basically. Now thickness, again clinical vignettes. Remember those I told you yesterday. Inflammatory bowel diseases in the forms of ulcerative colitis, Crohn's disease, regional enteritis and all those can lead to fibrosis, which can lead to thickness, increase in thickness of the intestine, and that can decrease the absorption of certain drugs. Vitamin B12 is a very commonly posed question here. Remember that, vitamin B12. Because terminal ileum is the portion from where it gets absorbed. So vitamin B12 and that thickness part comes pretty commonly. Now, coming to active transports. When it comes to active transport, we have already talked about it. Against the concentration gradient, utilizes a carrier protein, utilizes energy. Saturation will occur. The reason being is because you are dependent upon a carrier. Now, it is not governed by Fick's principle, since you are doing things opposite to the normal trends. You are moving away from an area of low concentration to an area of high concentration. So, is not governed by that. Facilitated, only one difference from active transport, that in facilitated diffusion, it is down the concentration gradient since you are not utilizing energy. Only difference from passive is that utilizing a carrier protein. It is also saturable in nature. Common examples, I already talked about sugars, then amino acids in the brains, certain anti-cancer drugs from the antimetabolite group, antiviral drugs, adenosine and certain vitamins. Most important of them is vitamin B12. Now, pinocytosis, phagocytosis, we are not worried about those. Certain large molecules which are pretty big enough, more than the size of 1,000, they might be utilizing this pattern. Majority of them are basically those vitamin B12 receptor complexes, RN transferrin complexes and so on. So pinocytosis, endocytosis, exocytosis, not much of a worry for us. Now, once the drug has moved, then we're going to talk about a little bit more about absorption. That was about permeation. When it comes to absorption, the determinants are same as we talked about for permeation. All are same basically. That's what we have talked about. Solubilities, those surface areas and all those are also there seen with absorption. Now, when it comes to absorption, always remember some amount of absorption will occur by all the routes except one route we talked about yesterday, and that is intravenous. Intravenous route, you are directly putting the drug into the bloodstream, systemic circulation. So all these process of permeations, all these process of absorptions are not a worry there, since you are putting the drug directly into the blood itself. Now, when it comes to oral route, there are two more things that we have to remember. You might have seen we take those big tablets or capsules, which have sometimes pellet inside those. Sometimes you might have found there are certain drugs or tablets which are coated with something because they might be destroyed in your gastric juices and so on. So before the drug can get absorbed by the oral route, there are two more things that we have to remember. One is disintegration and the other one is dissolution. Just to bring it out, that these are two more terms that are there, never ever quizzed. Just to remember that when you are taking a drug by the oral route, it should disintegrate into smaller particles and then it should be dissolved and then it gets absorbed. Now, intravenous, we already talked about it, that you are putting the drug into the systemic circulation. Whatever is injected is reaching the systemic circulation. Now, there is a term we talked about yesterday also, and I am repeating it again, that is bioavailability. This is a term which will be very commonly used in pharmacology. Bioavailability means that how much amount of the drug is actually available to produce a response in the systemic circulation or at the receptor site after all those absorptive patterns have taken place. In simple terms, how much is available to the biological system, as simple as that. Intravenous route, it is 100% because you are putting everything into the blood. There are no changes to that. But when it comes to other routes, bioavailability can range between 0 to 100% depending upon those routes. Now, why we have low bioavailability by other routes? Common example, think of the oral route. When you are taking a drug by the oral route, it will go to the GIT. You have your various enzymes, acid and everything over there. The drug might get destroyed there. We talked about a common example yesterday, insulin. Insulin can never be taken by oral route. Morphine is another very important example. Can you believe morphine has 100% absorption through the GIT, but it is still very less used by the oral route. Reason being is, just wait a minute, the reason is that when you are taking a drug by the oral route, some is getting destroyed in the GIT, that's one thing, but once the drug gets absorbed, it comes into the portal circulation, it will come to the liver. Liver is the major site of metabolism for all the drugs, whether they are coming for the first time or after they have produced a response. So if a drug is going to a place which has the maximum metabolic activities, what it will do to the drug? It will take some drug out by providing that metabolic pathways to it. That means you are losing drug even before reaching the systemic circulation. That is the problem with morphine. 70% of the drug is lost during this first passage itself. If somebody is taking 10 milligram, only 3 milligram will reach the systemic circulation. And when it comes to injectable preparations of morphine, it's 100%. That's why when people who abuse morphine, they normally take shots rather than taking tablets. That's the reason. Now, so that is called as first pass metabolism for those drugs. That is, you are losing drug through the first passage through the liver, portal circulation, and so on. So always remember this. Now, when you are using drug by intramuscular route, you are bypassing the liver. Then how come you are losing it? You are putting it into a muscle mass, intramuscular. It will get absorbed from there, depending upon how much amount of blood vessels are there. So you will lose some amount over there also. Now, anything that bypasses the liver will be having less losses. Always remember one route, we talked about it yesterday also, I am repeating it again, that was rectal route. People always have a feeling that you are giving drug via the rectum, you will bypass the liver. You will never bypass the liver even if you give it by rectum. Reason being that analytical question that we talked about yesterday. You have your superior rectal vein, inferior mesenteric going into the splenic, combining with the superior mesenteric and forming the portal vein. And when the portal vein is formed, the drug is already going to the liver once again. So that was one thing about rectal that we have to remember. Buccal routes, sublingual routes are very important. Inhalational routes are very important. These are the routes which bypass the first pass metabolism and are extremely rapidly acting drugs. People who might have worked in India, they might have seen a patient when they are called for a patient with myocardial infarction or angina. What is the first thing people do? 4 tablets of aspirin sublingually. That's the reason. because the effect comes pretty rapidly. So sublingual administration is a very rapid administration, always remember that, because you are bypassing those losses. Now, factor affecting absorption, we have already talked about those. Solubilities, dissolution.
Doctor,
Yeah.
wouldn't those rapid reabsorptions of the drugs will come with the side effect profile?
It depends how much you are using in those patients. And plus, yeah, go ahead.
So, for example, inhaled insulins now that are being used in acute cases.
Very less.
Very less.
Very less. The viabilities are very poor with those. We are still in the stages of stage 3 and all those stages only. Like Israel, pharmaceutical companies in Israel, they are trying to produce that oral insulin. It is considered to be an oral insulin, but actually it is not an oral insulin, it's a buccal insulin. So we are trying that out, but those inhalational insulins and all those giving very varied results. It's not being used as such. We are still relying on those intravenous preparations, those rapid acting insulins, we are still relying on those only. And always remember one thing, when it comes to drugs which have to be carefully monitored and triturated, intravenous route is the best route, because you know what you are giving, how much will reach, and how much response will be coming. If you use a drug by oral route, you do not know how much time it will take, how much will reach, because people have variabilities. Same dose might give a different response in me, same dose might give a different response somebody else because of the absorptive patterns. So always remember that if a drug depends upon acidity to get absorbed, and my pH is slightly on the higher side, the absorption will be poor. So intra-patient variabilities are very high when it comes to routes other than intravenous routes. So wherever strict values or levels have to be maintained, it's always better to go for those infusions and all those intravenous routes. Fine. Dissolution we already talked about, concentration, blood flow, again an important thing. When it comes to absorption, always remember blood flow do play a part. Subcutaneous route, intramuscular route. Both are bypassing the liver, but still absorption through the intramuscular route is slightly faster in comparison to subcutaneous because of larger amount of those blood vessels. Absorbing surface, larger the area, better is the absorption. Like when we talked about intestine yesterday, we have villi, microvilli, large surface areas are there. And remember one thing, yesterday we talked about that acidic drug in an acidic media will be lipid soluble. Fine? If I tell you aspirin is an acidic drug, from where it should be absorbed more?
Stomach.
It doesn't. The reason being is, intestines have very large surface areas. And the upper part of the intestines, the pH differences are not to that an extent. So with aspirin and with other acidic drugs also, even though we say that they should be better absorbed from an acidic media, but the size of stomach is so small that the larger intestines absorbs more of a drug, even though if it is an acidic in nature. Then pH, we already have talked about, contact time, very important. Now, one more thing. Nowadays, when it comes to exam questions, things which can be reproduced without the involvement of physician are the in thing right now for making questions. The things which a patient can produce on their own. Because a physician will never do anything that will create a problem. He'll try his level best. But when it comes to involvement of a patient on its own and create a situation, that becomes a very important question for exams. Now, why I brought about this thing? Contact time. The majority of the absorption takes place from intestine. If somehow I can delay the gastric emptying, what I'm doing? I'm delaying the amount of drug reaching the intestines that will delay my absorptions. Any problem with that? We are utilizing this pharmacologically nowadays for diabetic patients. You must have heard about incretins. You must have heard about amylins and all those. Now we are getting amylin analogs, incretin related drugs, which do the same thing. They delay the gastric emptying. What is incretin? What is amylin? Ando, GIT. Don't look at me like that, please. What is incretin? What is amylin? These are hormones which are released in your GIT in response to high glucose levels and carbs. Amylin comes along with insulin. So they control those levels. And what amylin normally does, it delays the gastric emptying basically. So amylin related drugs are doing that. So we are using it pharmacologically also. But how come it becomes important for our exams? Look, what governs your GI motility? Autonomic nervous system. Which one? Parasympathetic. If I give or a patient takes an anticholinergic drug, what it will do to the motility? It will decrease it. No problem with that. What is an over the available or over the counter drug available that has anticholinergic properties? all antihistaminics. Diphenhydramine and all those, they possess that. So if a patient who's taking an antihistaminic like diphenhydramine, which possesses some amount of anticholinergic property, what it will do? It will delay the gastric emptying, and that can lead to alteration in the absorption of other drugs also. So that's why that is very important for us. Now, when we talk about antidepressant drugs, when we talk about antipsychotic drugs, the conventional, not the new ones, the old ones, they all possess anticholinergic properties. So anticholinergic properties, alpha-1 receptor blockage properties will stick with you throughout the whole of pharmacology, remember this. So wherever, yeah, go ahead.
No, sorry, I was going to
No, go ahead, no problem.
Okay, so when you say we delay the gastric emptying,
You delay the
you're
absorption.
talking about in relation to contact time, we increase the contact time. That's the whole.
But
Is that what you said? Sorry.
no, what I'm saying is you are delaying the gastric emptying. So the time at which it should reach the intestines, it will be delayed.
Okay.
So when it will be delayed, only small amounts will be going there. Absorption will be delayed.
Okay.
Because absorption should take place from intestine. If you slow down the gastric emptying, less amount is reaching, so you are delaying the absorption basically. That's what it is. Now contact time, more to it. Anything that can increase the GI motility. Suppose you are using a purgative in a patient suffering from diarrhea, that will delay the contact time. That can also result in a delay in the amount of absorption. Now, another issue. Anticholinergics will slow down the GIT. If you look at it in the other way, will slow down the GIT. If the drug has already closed into the intestines, what it will do? An anticholinergic drug, it will increase the time for absorption. So you can look at it in all ways. Now, anticholinergics, look at it in two ways. Number one, you are delaying the gastric emptying. That is one thing that you are doing. Number two, what you are doing is you are also delaying the movement through the intestines. So if you look at it in both ways, both things can happen around, depending upon where we are talking about. If the drug was still into the stomach, it will be delayed, it will be slower. So the absorption will be slower, but the contact time is more, so more might come in. Look, this is your stomach. It has to come to the intestine. Fine? I'll just draw a graph for you. This is the absorption pattern, say. The drug has to come to the intestine to get absorbed. If I slow down my gastric emptying, what is happening? The rate of rise of absorption, will it be faster or it will be slower? It will be slower. But what about the total absorption?
Increased.
It will be increased. Why it will be increased? Because you are delaying the motility also in the intestines. So more contact time now. So the total absorption will be increased, but the rate of rise will be on the slower side. Now if I increase the motility, that is say a diarrhea or a patient being given a purgative drug that causes a treatment for constipation, I might present the drug faster to the intestine, but the contact time is so less that the total amount of drug that will be absorbed will be on the lesser side. That's what I was trying to tell you. So always remember, you can have two faces to the same thing itself only. Even though the drug is coming faster to the intestine, but the absorption will not be much. The reason being is because the contact time is less. So that was it regarding the contact time. Now coming to plasma level curves. Now once again, curves are very common in our exams. This is a typical plasma level curve in which the plasma drug concentration is being plotted as a function of the time. That when you administer a drug to a patient, how it is coming into the blood. Now one more thing, is it a oral preparation? Not a oral, is it a intravenous preparation that we are talking about or any other route?
Any other route?
Why it is not intravenous?
Intravenous goes.
It will never go from zero to this.
Yeah.
Intravenous always starts at the peak, because when we talk about intravenous route, you are putting the drug directly into the systemic circulation. The concentration at time zero should be highest or should be lowest?
Highest.
Should be the highest, because after which the drug will be eliminated. So you will gradually go down. So intravenous will always be starting at the highest point because you are putting everything into the blood. Now, coming to this, we'll take it as oral basically. The drug is being given to a patient and the drug starts rising in concentration. Look at the gap here. Why this gap?
Takes time.
Because there will be time that will be required for the drug intake and from the absorption to take place, from the absorptive surface to take place. This is called as the lag phase. Look, this is all theoretical. Once you see it in a patient, this will basically start from here itself only, because you start taking it from that point only. So that is just a small theoretical part here, that there will be a small lag phase till the time the drug appears in the blood. Now once it appears in the blood, you are gradually seeing an increase in the concentration. Why you are gradually seeing the increase in concentration? Because at this point, the major processes which are involved with this drug is absorption. Distribution is not as strong, elimination is not as strong in the beginning. Absorption is more important here at this moment. So absorption is more. Gradually the concentration is increasing. Gradually going up, reaches a point where it has the maximum concentration, or Cmax. That is the maximum achievable concentration for that particular dose. And that is called as Tmax at time t. Now if I ask you which is the major process working on this ascending curve, it is the absorptive processes which are stronger here. Now once you reach the Tmax, there is a dip. The concentration is gradually going down. Now if I ask you why this is going down, in the initial phase, when the concentration is going down, it is mainly the distribution which has become important. And a little bit of elimination also has started setting in. You gradually are going down, and then elimination becomes the major process, and gradually the concentration will reach the level at which we basically started from the beginning itself. Easy to understand if you look at this. This is just a box. Now when it comes to concentration within our system, it is dependent upon three things. Number one, how much you are administering. Where the drug is being distributed, in how much amount, that is distribution, and then elimination. Because how much stays here in this system will be dependent upon how much you are putting in, how much is being distributed out into the other systems, and how much is being eliminated. Now when you start giving a drug, absorption is more, you are giving the drug in. Distribution and elimination have not set in, that's why we are going up. When the maximum concentration has been achieved, distribution and elimination also starts coming into play. You are distributing the drug gets distributed to begin with, and then elimination comes in. You have stopped giving the drug, absorption has gone down, elimination and distribution becomes more prominent now. That's why you have a fall in concentration. These are all pharmacokinetic parameters. Now coming to a pharmacodynamic parameter here. We didn't talk about effect of the drug up till now. Look at this slide. This is the minimum effective concentration. Look, appearance of a drug in the systemic circulation does not mean it will produce a response. There has to be a level in the blood that has to be achieved to produce a response, which is called as minimum effective concentration. Now once if you look at the chart again, you gradually are increasing the concentration. As the concentration is rising, there will be a point that will come which will take this concentration beyond the minimum effective concentration. That means now the effect of the drug will start. You are further increasing the concentration because absorption is still the main thing. You reach the peak, and then distribution and elimination starts taking over. Now once you are distributing the drug and eliminating the drug, what is happening to the concentration in the blood? It is going down, it is falling. Now it will once again cross the minimum effective concentration, and then it will fall below it. That means the drug will produce a response only when the amount of drug in the blood is more than the minimum effective concentration. What you label that as? Duration of action of the drug. That is the time during which the concentration of the drug was higher or more than the minimum effective concentration. That is my duration of action. As soon as I fall below it, my effect will be gone. Now, what is this point called as? For the first time when you went beyond the minimum effective concentration, time of onset for a drug. That is the time required for the initial appearance of the effect of the drug to show. That is called as onset of effect of the particular drug. This is your pharmacodynamic parameter because it is about effect. Yesterday we talked about pharmacokinetics is about how the body deals with the drug. absorption, distribution, elimination, metabolism before that. And what is pharmacodynamics? What is the drug doing to the body? The response. And that is about this portion that we have talked about. So these are few things regarding this. Now, how can I quiz it? There are different pharmacokinetic processes which are involved here. Which are those processes? Number one, absorption. Number two, distribution. Number three, metabolism also and elimination also. If I give you a graph that is different from this and ask you to figure out what the changes are and why those are happening, that is the way we break these questions up. I'll give you a very common example here. This is your normal one. If I give a B graph, this was A, this is B. What has been slowed? It's slowed in this or delayed in this? The absorption. Now, write this down. This is a very common example that is quizzed. There are other examples also, because since we have not talked about those drugs, there's no fun going over there. One very common example that you might have heard. Heard of a drug by the name of tetracycline? That's an antibiotic. Yes. What is the important property of tetracycline? That must have been, like, not must have heard about somewhere else. It chelates calcium. Remember that. Tetracyclines have a property of chelating calcium. Now, one more thing. Examiners are really bad. Why I say examiners are bad? They'll never say calcium. They'll talk about a patient taking ricotta cheese. Or loves, that's a cheese. It's a dairy product, calcium.
What do you say?
It's a dairy product. Milk has calcium in it. A person loves going to pizza corners. No, we are talking about anything. Eats pizza every day. Once again, cheese coming in. Once again, calcium coming in. So you will not find a question, calcium written somewhere. So those same sort of questions show up all the time. Not sometimes, all the time. So search for those minor points somewhere. So remember those. Dairy products. Dairy products contain calcium in them. Because those are basically milk. Now what tetracycline does? Tetracycline chelates calcium. Now calcium, when you chelate something like calcium, what calcium is? It's a charged particle. That means tetracycline becomes charged now. When a drug becomes charged, is it lipid soluble or water soluble? Water soluble. Absorption decreases. You might see when you see a box of tetracycline, a box warning on it. Pregnant females and kids should not be given this drug. Why? This is the reason. Yeah? That's the reason. It should not be given to pregnant females and young growing kids because it chelates calcium. The bone growth will be hampered, the teeth growth will be hampered. You'll have those discolored teeth if the drug is given to a pregnant female. Those brown discolored mottled teeth will be there, serrated teeth will be there. So tetracycline, extremely important for us. Now another thing about tetracycline, I'll point that out here itself only because it will be repeated again and again. What about expired drugs? Just a common question, an ethical question. Expired drug. If the drug expires, do you ever take it?
If it's a single substance.
No, you're not supposed
Tetracycline is a single substance.
You're not supposed to take expired drugs.
People take it, I'm telling you. People take 2 years old, 3 years old, ibuprofen, Advils and Aleve also, Tylenol also. Tetracycline is one drug, should never take it. Expired tetracycline causes a syndrome which is called as Fanconi syndrome. Fanconi syndrome. Kidneys are totally gone. You will not survive. So tetracycline is one drug. If it is expired, don't even think about taking that drug. Ibuprofen and Advil, people take a lot. Aleves and all those. But remember tetracycline for that. A drug that is very commonly used for that reason.
Which syndrome?
Fanconi. F starts with an F. Fanconi syndrome. You can search for it, read about all about it, what actually it is. So this was a little bit about it. I can bring about changes in elimination, I can bring about changes in metabolism, the graph will keep on changing. And you can be quizzed on those basically. Now, effective drug concentration. It is the concentration that you require at the site of the receptor where the response has to be produced. Now, other than topical, basically effective drug concentration is what we have a concentration in the blood as such. Topical is different. That you apply it topically, the concentration might be different. But when it comes to other routes, whatever you find in the plasma or in the blood, basically is the concentration that you normally talk about. And we have already talked about that effective drug concentration is dependent upon three things. Which were those? How much you take, what is your distribution rate, and how fast you are eliminating the drug. Three things. Because anything that comes into this box will depend upon how much you are putting in and how much you are taking out. That's it. How much you are putting in is your administration, that is your absorption. How much you are taking out of the systemic circulation will depend upon your distribution or elimination. Faster the elimination rate, faster the distribution, the concentration in the blood will keep on going down. So the final result basically depends upon all those three processes. Now, when it comes to distribution and elimination, look, if you know that dosing rate, that at what rate you are giving the drug to this patient, the two other parameters which are time dependent, which can tell you everything about the drug, is your distribution and elimination. Distribution to which place? To the whole volume. We label it as volume of distribution in your body. And what is elimination from your body? How fast you are clearing the drug from your body, that is called as clearance. So if you know how much is going in, the two parameters which becomes very important for us, one is volume of distribution and the other one is the clearance for that particular drug. Bioavailability we have talked about quite a lot. Just a small thing to add here. We talked about it yesterday also. And that was P glycoproteins. Those are here. Now, what P glycoproteins are? These are certain proteins which are normally present in some cells, especially in your GIT. Now, what is the action of these P glycoproteins? What these P glycoprotein does is they extrude the drug out. That is, the drug enters the cell and they expel it out. That's what they do. So, if you are having a system which expels the drug out, what that will do to the absorption?
Decrease.
It will decrease. That's what it does. Now, why this is important to us? Because there are certain drugs which are P glycoprotein inhibitors. There's some more later on that I talked about, but these are few over here. Remember one drug which utilizes P glycoprotein for expulsion, and remember that is digoxin. Now, digoxin is a very narrow spectrum drug. Now, what the hell is this narrow spectrum? Look, when you prescribe a drug to a patient, what is the most important thing that should come into your mind? That it should produce a response. But that's not the only thing that it should produce a response. Because producing a response will never land you in trouble. The other thing will land you in trouble. What is that? Toxicities. So we have to have a spectrum which should be wide apart. What is this spectrum? We call it as a therapeutic range. The minimum effective concentration, the concentration at which the drug will give a response, and the minimum toxic concentration, the minimum concentration at which toxicities start appearing. This is my therapeutic range. My drug should fall between this. It should be towards the minimum effective concentration. It should be far away from my toxic ranges. Because I do not want that. Skype started. Pretty good with that, 10 minutes. So, that range has to be wide. But if you have a narrow spectrum drug, what is the problem? Slight change in absorptive patterns, slight decrease in elimination, slight decrease in metabolism will push my concentration towards which side? Towards the toxic side. That's the problem. Digoxin is one drug which is a very narrow spectrum drug. Anything that will alter its metabolism or its excretion will lead to a lot of problems. Now, digoxin is a life-saving drug. It is given for patients suffering from congestive cardiac failure. But always remember, majority of the life-saving drugs also carry problems with them, which are quite a lot. Digoxin itself is an arrhythmogenic drug, can produce arrhythmias. So, a lot of problems are there with digoxin. Now, narrow spectrum, anything that can alter its concentration can be a problem to me. That's why this was important to us. That if you give this drug to that patient, that can block those P glycoproteins, you got a problem. Now, another thing, grapefruit juice. Patient suffering from cardiac disorder, the first thing that the person thinks about, hey, why not take grapefruit juice? The problem with grapefruit juice is that they inhibit P glycoproteins. So if a patient is on digoxin and is on grapefruit juice, you got a major problem there. So there has to be a far apart. Even if you want to take grapefruit juice, the administration of the drug and the grapefruit juice should be far apart. Now another issue, grapefruit juice does not only inhibit P glycoproteins, it also inhibits the enzymes which are involved in metabolism. Now, who will be prescribed grapefruit juice? Normally, patients with cardiovascular disease, obese individuals who want to lose their weight. And majority of them will be having some amount of atherosclerosis also. And when you are suffering from atherosclerosis, you will be using lipid lowering drugs. Most commonly used drug world over is statins. That is the problem here. Grapefruit juice inhibits the enzyme which metabolizes statins. And what is the major worry with the statins? The major worry with the statins is hepatotoxicity is always there. That's it. They cause myopathic disorders. Patients always complain of severe muscle aches. And that's not the issue. The issue is if they accumulate too much, they can cause a disease by the name of rhabdomyolysis, where your muscle starts getting destroyed. That's the problem. So grapefruit juice, statins, grapefruit juice, digoxin, big worries for us. They have to be far apart when you are administering it. Fine, so that was a little bit about P glycoproteins. Now, another issue with bioavailability. There's a drug which has a bioavailability of 70%. There's another drug which also have a bioavailability of 70%. Fine? Say one is Tylenol, paracetamol, acetaminophen, the way you want to call it, from one manufacturer. The other one is coming from B manufacturer. Fine? Both are Tylenols, but one coming from one manufacturer, the other one coming from the other manufacturer. Both have viabilities of 70%. Can you substitute them?
It depends.
What? It depends on what? That's what I'm asking.
Depends on.
Don't tell me the medical reps that they're coming to you, buy this one, I'll give you this one.
No, it depends on. It depends on.
Depends on what?
Pharmacological effect that you.
Both are having 70% bioavailability. That's what it is.
Bioavailability does not necessarily translate into its therapeutic equivalent effect.
What is that therapeutic equivalent effect? That's what I'm asking.
Okay.
Just hold on. A drug has a 70% bioavailability. But bioavailability means that 70% is getting absorbed. We didn't say at what rate. One might be taking only 4 hours, the other might be taking 12 hours. How can you substitute? So how can you substitute? The best thing is to correlate all those things around. The best thing that can judge bioavailability is plot a graph of that concentration time and then find the area under the curve. Area under the curve tells you about each and everything. It incorporates everything, whether the absorption, the elimination, and everything. So area under the curve is important to us when it comes to all these parameters. And if somebody asks you which is the best parameter for judging bioavailability, always remember it is area under the curve on a concentration time graph. That's very important to know. Now, how can you calculate the bioavailabilities? Want me to stop for some time?
Sure, please.
Sure and please don't go together.
Yes, now.
One is a request, the other is a command.
Yes, now.
Time starts now.